From Microbe TV, this is Beyond the Noise, episode number 28, recorded on January 31st, 2024. I'm Vincent Racaniello, and joining me today is your host, Dr. Paul Offit.
Hi, Vincent.
This is the video version of Paul's column on Substack called Beyond the Noise, Cutting to the Chase on Important Health Topics. And today we're going to have a look at Paul's last column entitled Trump's COVID Infection. So maybe, Paul, we can start by having you give an overview of the course of his illness.
Sure. So in mid-October, former President Trump was diagnosed with COVID and taken to the Walter Reed Hospital. He had let his infection go on for fairly long, so that by the time he got to the hospital, he had pretty severe pneumonia. He was considered for being ventilated, which would have meant that probably Mike Pence would have taken over as commander-in-chief, but he was sick. And so he was treated with a variety of medications. He was given the antiviral medication, remdesivir. He was given, even though that actually, the antiviral really wasn't licensed till the end of that month. And he was given the monoclonal antibody Regeneron, which also wasn't really available, at least for the general public, until November. And he was also given dexamethasone. He survived. He was obviously back in his office a few days later, convinced that it was the monoclonal antibody Regeneron that had saved his life.
Now, he tested positive but didn't do anything for 7 days. Why is that? You would think the commander-in-chief of the U.S. would have physicians who would say, let's do something immediately, right?
I don't know why he made that choice. Obviously, it was the wrong choice. Had he been able to identify had he been able to admit, I think, to the general public that he had COVID, that he could have been treated earlier. Now, in theory, the one thing that was available, starting from the beginning of this pandemic and had been available for 100 years, is convalescent sera. I mean, right. Convalescent sera was underutilized and wrongly used. We tended to initially use convalescent sera in that original Mayo Clinic study in hospitalized patients, and it would be much better off giving it during the viral replication stage, the first phase of illness, which Dr. Griffin has been very good at explaining, that early stage as compared to the immune stage later could have really prevented him ever from being in the hospital. But he didn't admit to either to himself or to the public that he had COVID. And in fact, he proceeded to infect other people, like Chris Christie, for example.
All right. So you, in this article, you talk about what actually saved his life. So maybe we should talk about the two stages of COVID to set up for that.
Right, so which is true for many viral infections. The first stage, viral replication, is key. And so agents that decrease viral replication, like monoclonal antibodies, which prevent virus cell binding, or antivirals, like remdesivir, which is a replication, inhibits replication, or now we have protease inhibitors like Paxlovid. I mean, those early on clearly make a difference, clearly decrease your chance of going on to develop severe disease. But by the time you develop severe disease, which takes time, I mean, it takes 7 days, 10 days, 14 days to develop severe disease. By that time, viral replication is much less important as contributing to the pathogenesis of the illness. At that point, it's the immune response that's causing the symptoms. And in the case of Donald Trump, flooding his lungs with white cells. So at that point, in order to save his life, you need to blunt the immune system. You could argue, and this is something that's always sort of perplexed me, at some level, it's your immune system that kills you. It's not the virus. It's your immune response to the virus that kills you. And so you're begging the question, why? Why would it do that? And there was an article years ago in the Annals of Internal Medicine that sort of tried to look at that question. And they posited that your body gives you a certain period of time to rid yourself, in this case, of a virus. And if you're losing, then you sort of get culled from the herd so that you don't then affect other people.
So we now know that it's important to give antivirals early in infection to curtail the viral phase, as you say. So why even though he was 7 days after testing positive, why did they give him these the remdesivir and the monoclonals so late?
That's a great question. And I think the answer is because we had very little experience with either of those products, either the monoclonal antibody Regeneron or the antiviral remdesivir, neither of which had been licensed or authorized yet. So you didn't have much data. In fact, if you look at the early data with remdesivir, on the first 100 patients or so, that was all in hospitalized patients. I mean, you would have argued that if you're going to use it, you should use it early in people who are at highest risk of developing severe disease, i.e. those people who have the kind of comorbidities that put them at high risk. That's not the way those original studies were done. Same thing for monoclonal antibodies. That's not the way those studies were done. So you saw some benefit, but a very mild benefit. And so I think we learn as we go. But people look at this and they think, here, now we know that this is not, these products, the antiviral, the monoclonal, are not going to work well late in illness. So why did we do that? Because we learn as we go. And I think that we're largely intolerant of that kind of learning curve.
It's interesting because we have a lot of experience with other viral infections. We know you have to, for influenza, you have to give antivirals within 24 to 48 hours. So this whole story during COVID really was fascinating to me, that we did clinical trials late in hospitalized patients before. I don't understand why the light didn't go on earlier.
I agree with you. For me, the thing that was most upsetting in that year, because that was a terrible year, right, 2020. I mean, the virus came into this country early in 2020. At least the first recorded death was sometime around the end of February of 2020. And then 1,000 people were dying a day, 2,000 people were dying a day, 3,000 people were dying. We had 200,000 deaths by May. We had 500,000 deaths in this country by December. I mean, we were helpless. We had nothing. Again, it was the antivirals in October, the monoclonals in November, and not vaccines not till December. So what did we do? We isolated, we quarantined, we masked, we tested and tested and tested. We shuttered schools, we closed businesses, we restricted travel. That's all we could do, was try and limit human-human interaction for a virus that was transmitted largely asymptomatically. We were stuck. But the thing that upsets me the most was the convalescent sera, because we had an expanded access program for that. People did give generously, and I think it's one of the many bright lights of this pandemic. People were perfectly willing to give their blood and sera to help others. But we didn't do those studies the right way. That original Mayo Clinic preceding study was in hospitalized patients. There's no reason we couldn't have done that earlier. And the estimates are that we probably would have saved at least 20 to 30,000 lives early on.
Hopefully the next pandemic will remember that,
I hope so.
So I'm actually impressed that his physicians gave him dexamethasone. So what were they thinking, Paul?
Right. So the thinking was, let's suppress his immune system. And it's a slippery slope, because on the one hand, it is your immune system that saves you, in the sense, right? I mean, antibodies, prevent virus cell binding. Antibodies are made by B cells. The T cells, T helper cells, help B cells make antibodies. And then cytotoxic T cells, which also respond fairly rapidly and well when you're severely ill, also kill virus-infected cells. And so when you give steroids, you're suppressing the immune system. And so that is that sort of double-edged sword there. But they did give dexamethasone, which saved his life. I don't think that's what I don't think that's what former President Trump thought saved his life. I think he had said he thought it was the Regeneron, but it was a dexamethasone. So here you had these two products which were not quite yet authorized, but you had another product which was available since 1957 that ultimately probably saved his life.
So even though the use of Dex in COVID was not very established, the physicians knew from other infections that it could be useful, right?
Exactly. And it universally suppresses your immune system. It suppresses all aspects of your immune system. B cells, T cells, neutrophils, all aspects of your immune system. It's a blunt instrument, if you will, but in this case, an effective one.
And so if they had given it to him early, that would have been bad, right?
Exactly, because early on, when the viral replication is king, you want to be able to make antibodies. You want to be able to make, T cells that kill virus-infected cells. And I think that the degree that you suppress that is the degree at which you only allow viral replication to continue massively.
Now, if President Trump were to be infected today, test positive, what should be done?
So if former President Trump were infected today, I think what he should do, because he's older, he's now 77, he's overweight, he should take Paxlovid as soon as he knows that he's infected. First of all, he should test immediately if he has respiratory symptoms, and if he's COVID positive, he should treat himself with Paxlovid.
And so he would need to take Paxlovid within the first 5 days of testing? Is that the guidance?
Yes, and preferably in the first 3 days, yes.
Right. Now, as you know very well, there's a lot of backlash against Paxlovid. There's this idea that somehow it's involved in what's been called rebound, which is nothing other than the inflammatory phase of the infection. So do you think that his physicians would be immune to that bias?
I hope we've learned enough now to realize that as you move into the second stage of illness and your immune system starts to take over and then your symptoms worsen, that's what's happening when you finish your course of Paxlovid. You're just entering your second stage of illness. There is no such thing as Paxlovid rebound. You could call it COVID rebound, but it's not even a rebound really. You're just moving into that second stage of illness. I hope we've put an end to that. I think where Paxlovid, where we suffer with Paxlovid, because there are a lot of people who are admitted to the hospital and a lot of people who die, whose deaths could have been prevented by treating early. So I think one is what you said, this sort of fear of this false notion of Paxlovid rebound. But the other is Paxlovid does have many drug-drug interactions. And I think for some physicians, they think, let's just forget it. There's all these drug-drug interactions. But it's always a matter of relative risk. And is it okay to stop one of those drugs for a few days while you're taking, Paxlovid, because Paxlovid was going to have a greater chance of saving your life than stopping those drugs would cause you to die. So I think we're not good at weighing relative risks or benefits, because I think there are a lot of people in whom you could stop a drug for a few days while you're giving Paxlovid, and we don't do that.
It's interesting. You wrote a few columns on how words can be misleading, right? And I think rebound is the wrong word in this case. It's not. Rebound implies that there's a recurrence of replication, but that's not the case at all, right?
Right. Not at all. And we did contribute to that. I don't remember early on, Dr. Fauci had taken Paxlovid and then had, as he moved into the second phase of illness, started to have more symptoms. He then took a second course of Paxlovid later in his illness, which sent in many ways the false message that continued viral replication was the problem, when the problem was really an increase in his immune response. And so that second course of Paxlovid probably did little to nothing for him. But this still happens. I mean, I was on service a couple of weeks ago, and we had a patient who was 10 days into illness, and still, the instinct was to start an antiviral, even though at that point there was probably the viral replication was really not a critical part of the pathogenesis for the illness anymore.
I think rebound is unfortunate for reasons you said, and it seems to be with us because people mention it all the time. And I think once a word like that gets into circulation, it's very hard to pull it out.
I think that's exactly right.
All right, we'll put a link to this column in the show notes, and you can read more about it. That's Beyond the Noise with Dr. Paul Offit. Thank you, Paul.
Thank you.